a few remarks about the significance of COVID at this present moment. The COVID has created a critical lens, I think, for many people, both locally, nationally, and globally. It's highlighted how fragile our links are locally, nationally, and globally. It also has disrupted seemingly settled patterns of work and living, while causing widespread sickness and death. It has also exposed blind spots in our healthcare system and the inadequacy of the readiness of our public health organization. It too, and I would say above all, has engendered uncertainty about the present and even fear about the future. What's been striking to me is how, in general, our society has attempted to make sense of COVID, particularly in the US context. And I want to briefly describe two narratives in which COVID has been filtered as a way to make meaning. The first refers to the sort of idea of the America that many people like to see. And that is the idea of recognizing the courage of health and emergency first responders on the front lines in hospitals and in the community, the mobilization of our institutions of civil society, such as businesses, food banks, shelters, faith communities, to support first responders as well as vulnerable populations. And of course, the articulation of inclusive messages, we are in this together, and various and many gestures of appreciation. And yet there's a second narrative that's equally relevant, and it's the narrative of the America that exists every day. And so during COVID, there has been a discovery of essential workers who have little alternative but to work in high-risk areas, driven solely by a mission and a desire. And very often that includes women, people of color, documented and undocumented immigrants. A second thread of this narrative is a differential impact of infection, sickness, and death among underserved and vulnerable populations. And one wonders, are they vulnerable because they're essential workers, or is there something about the conditions that produces their vulnerability? And finally, we've seen scapegoating of people, anti-Chinese rhetoric, the proliferation of anti-Black racism online, and also spikes of concern that are directed against a large number of different populations in our society. And so I am looking forward to learn a great deal from our distinguished panelists about COVID, but how we can respond within an equitable mindset. Thank you.
Thank you, Vice Chancellor Haynes. It is now my pleasure to introduce our panel moderator, Dr. Candice Taylor-Lucas. Dr. Taylor-Lucas is an associate clinical professor in our Department of Pediatrics in our School of Medicine. She's also the Associate Director of Pediatrics Residency Program and the co-director of LEAD ABC. Welcome, Dr. Taylor-Lucas.
Thank you so much, Dr. Mayes. It's a true pleasure to be able to have the opportunity to be a moderator for this illustrious panel. We have a diverse ability to have a really diverse dive into the challenges COVID has introduced into our world. But in recognition of that, and before I take time to really acknowledge each of our panelists, it's also important to recognize the weight of COVID-19 and the fact that it really does, it exists, it is real, and it has a palpable impact on the daily lives of really every individual in our world and society. And sadly, over almost 1.5 million people, our individuals, have been identified as diagnosed with COVID and coronavirus. And we want to recognize those who have lost their lives. So as we begin this panel and as we begin our discussion, we want to ground our discussion with an awareness of the fact that this disease matters, and it matters in broad ways and has impacted many, but almost 88,000 lives have been lost. So we're going to begin with just a moment of silence. And so we'd like to observe a moment of silence that recognizes every 1,000 individuals who have lost 1 second for every 1,000. And we'll observe that now. Thank you. And that small, brief amount of time has felt like an eternity. And that truly does reflect the wave and change that we have all experienced in our lives in broad ways. And with that, we wanted to bring together a panel that would introduce broad perspectives and represent the voices of communities that often are unheard. And truly, we are excited to be able to have the opportunity to partner with our panelists. So I'll just briefly introduce each one, and then we'll have them introduce themselves as we address our first question. So with that, I'd like to start with Dr. Tiffany Willoughby-Herard from the School of Humanities and African American Studies. If you can please wave. And next, Dr. Alana LeBron from the School of Public Health and Chicano and Chicana Studies. Thank you. And Dr. Allison Holman from the School of Nursing, and Dr. Emily Dowd from the School of Medicine and Department of Family Medicine. Wonderful. So as we jump right into the discussion, and we'll start first with Dr. Tiffany Willoughby-Herard. And the question I'd like you each to answer is this. The COVID-19 pandemic has had diverse impacts on multiple communities in our nation, but it also has affected each of us uniquely. If you can please share how the COVID-19 pandemic has affected you, just you personally and your work addressing the broad needs of equity and inclusion. And Dr. Tiffany Willoughby-Herard.
Thank you so much for the moment to speak with you all. I want to begin by requesting that we all hold space for and memory for Breonna Taylor, one of the frontline workers, an emergency medical technician who was killed a few months ago, but under the watch of our COVID outbreak. And so I'm dedicating my remarks to her today. What is important to me is that we remember the pandemic before the pandemic. And that means thinking about the fact that we have a long history of not actively fighting against forms of disrespect toward Black bodies and Black people that has been sewn into the fabrics and the logics of our ways of providing medical health care and medical education. There's been a number of cases literally in the past 3 weeks of African American women in particular going into hospitals and then being sent back home. Part of the disparities that we are trying to wrap our heads around and really create space for have to do with a history of the disposability and instrumentalization of Black bodies. In fact, the film Unto the Well Runs Dry by Sean Utsi, one that I hope we'll be able to share in the summer with the medical school students, details a long history of anatomy training, relying on the particular specimens available because of the history of slavery. So you see a really a soft transition between the emergence of medical colleges here in the United States and the history of medical plantations. So one of the things I think it's really important for us to think about is that this pandemic that we're living in is not new. It's not new. And the exacerbation of disparity that we're having to face requires us to tell some really hard and honest truths about who we are as a society and who we care about and who we don't care about. So thank you.
Thank you. And thank you for grounding us with a face. To have a face to represent the fact a number is not a number is huge. And Dr. Alana LeBron, if you also could please share how this has affected you.
Certainly. Thank you, Dr. Taylor Lucas. So the pandemic has certainly exacerbated the very conditions that myself and my colleagues and community collaborators have been working together to better understand and address. Very briefly, my research focuses on the impact of structural racism and health inequities, seeking to better understand how these processes work so that we can develop intervention strategies to mitigate health inequities. And much of this work is in close collaboration with affected communities, ranging from projects where we're equal partners in the work to projects that are very community driven. And the central nature of this work is very relational. So before the pandemic, it would take the form of in-person meetings, of developing and participating in community organizing strategies that are very embodied, both individually and collectively. And as just one example of how the pandemic has shaped that work, we were preparing for an important community-oriented dialogue to process some research findings regarding the influence of structural racism on health inequities in Orange County. And it was also becoming clear to us in early March that the virus was here, and that while we needed really radical connection in order to affect social change, we also needed to practice physical distancing. And this was before this was a common practice, and before the shelter-in-place orders were implemented in California. And so just as one example, as a partnership, we determined that we needed to put that activity on pause, and that gave us the space to stand back and to reflect on this shifting context and figure out together, what does a collaborative approach look like in the midst of a pandemic? And so in several of the partnerships in which I'm involved, we are really seeing the pandemic not as a fleeting event that is exacerbating inequities socially, economically, and health-wise, but really as a slow-moving storm that profoundly heightens inequities in ways that are not always acknowledged by broader discourse, but that are powerfully experienced and known by affected communities. And so we are trying to figure out how to be together and to advance our work with COVID-19 really becoming another dimension of our ongoing work. And I want to take a moment to acknowledge the greater mortality risk in COVID-19 that we are seeing by race and ethnicity across the country and here in Orange County, with Asian, Black, Latino, and Native Hawaiian Pacific Islander residents being more likely to experience mortality risk than white residents in Orange County. Thank you.
Thank you, and thank you for sharing just the fact that this has been with us, and it's something that communities are navigating with recognition of their unique needs, and we also, as faculty and physicians and health advocates and professors, are navigating as well. And with that, I'd like to also have Dr. Holman, if you can please also share how this has affected you and personally and also professionally as you advocate for equity and inclusion.
Thank you. Thank you, Dr. Taylor, for the question. So for me, as a nurse and as a health psychologist, well, personally, I'm staying at home and doing my work. Professionally, this pandemic has ushered in an era of basically endless work because we have, my colleagues and I have started a study, a national study, to try to understand how this pandemic is being experienced by the country. So we have a large representative sample of Americans, over 6,500 Americans, and we're going to be following these folks hopefully for quite some time. And we're collecting data to try to understand what their emotional response is, the behavioral response, attitudinal responses. Importantly, this sample of individuals we have health data on them prior to the start of the pandemic here, and we're planning to collect health data in a year from now. And one of the things that I'm very interested in understanding and pursuing, precisely because of what Dr. LeBron just mentioned, which is the inequities in who is being affected by this disease, it's much more strongly affecting the underrepresented minority communities by a long shot. And so one of the things that I want to be able to look at and understand is what are some of those early indicators of potential worsening health outcomes for the underrepresented minority communities? How can we identify people early on from those communities to intervene and maybe prevent some of those downstream health effects, worsening health effects? So that's one of the things that my colleagues and I are hoping to do, that I'm hoping to do. And I was just in a research meeting before this in which we were talking about how do we think about and address questions like the communities who are being affected right now are largely underrepresented minority communities, Black communities, Indigenous American communities, Hispanic communities, or Latinx communities. So if you look at those communities, a lot of the communities that aren't being affected are more the white communities, and the question of privilege comes up, and the question of when do we see more protests being peopled by people from white communities more so, and less from underrepresented minority communities. And the question that comes up for me is, how do we understand when more people will get on board with understanding the need to stay at home and the need to engage in behaviors that protect all communities? Because it's the underrepresented minority communities who are who populate largely the essential workers, especially in healthcare. A lot of healthcare workers come from underrepresented minority communities. So from my perspective, we need to think about that. We need to think about what do we need to do to help raise awareness and consciousness in all communities about the impact that this disease is having on everybody, so that we can provide the care that is needed to the underrepresented minority communities. Thank you.
Thank you, definitely, for just broadening our perspective as well as we talk about this issue and incorporating a really key point. The community that is protesting in theory, has a privilege to protest. Not everyone is able to participate in those protests. So I really am grateful that you pointed that out. And Dr. Dow, if you can, please also share. You are still muted right now. If you can, please unmute. No worries.
Sorry, I knew this would happen. Sorry, everyone. It's an honor for me to serve on this panel. I work at a federally qualified health center, the UCI Family Health Center in Santa Ana, that serves a largely underserved, low-income Latino population. We have patients from very diverse communities, but primarily 75% Latinx or Latino. So I was abroad when a national emergency was declared and had to self-quarantine for 14 days before returning to work. And I had patients scheduled to see during those 14 days. Was feeling so bad about this, but I was able to conduct telemedicine from home, and that worked out without our having to reschedule our patients. I have continued to do telemedicine since. So in fact, 80% of our visits are telemedicine, 20% face-to-face for those who need to be examined for new symptoms or physical findings. And although there are limitations to a telemedicine encounter, many of my patients actually like it because they don't have to take time off from work. They don't have to get on 2 or 3 buses to get to clinic and wait in the cold exam room for anywhere from half an hour to over an hour to be seen. In fact, I was on the phone with a patient just this morning who was actually driving. He works as a driver and loved the fact that he didn't have to come in. And, lots of other people who were actually ironing at a hotel while talking to me on the phone. So on the other hand, I've spoken to a lot of patients who are with so much fear and anxiety and depressed mood due to the pandemic. Many had lost their jobs. They were anxious about choosing between paying their rent and utility bills versus putting food on the table. They also live in crowded households with children out of school who they can't help with the schoolwork because they're frontline workers and they can't work from home. When they do have the children at home with them, they couldn't help them with the schoolwork because they don't have the language proficiency or the education that they didn't achieve in order to be able to help them. So my question to myself and to my colleagues during this pandemic that has hit the hardest for the underserved, disadvantaged communities is, how do we help them? How do we help them so that they're not the hardest hit in Orange County? We know that it's the Latinx community, the Latinos, that are hardest hit. They have the highest infection rates and death rates, even in Orange County. In LA County, the hardest hit area I hear is Pico Rivera, which is 90% Latino. And so how do we prevent or equip our communities so that they're able to respond to the pandemic and keep themselves safe?
Thank you. Thank you for introducing that necessary question. And it brings to mind one of the questions that one of our registrants introduced. And so I'm going to bring that question in now, and actually would like Dr. Holman and Dr. LeBron, if you can also reflect on what was just said by Dr. Dow and this question as well. But the question was stated, what are some strategies that we can use as clinicians to work to improve equity during COVID? And Dr. Dow, I heard you specifically mention the help, if you will, that the telehealth visits have really just introduced an opportunity to allow patients to really connect with us in clinical settings from their home, and they've allowed physicians and providers to also connect with families from their homes as well. It does introduce another divide, though, with access to just the internet, access to resources to be able to either engage via a video encounter versus phone and things along those lines. And just want to think broadly, though, about that and the question about some strategies that we'll say clinicians and healthcare providers can use broadly. Dr. Holman, if you can please start first with your thoughts, I'd appreciate it. And you're muted right now.
Thank you.
No worries.
Sorry.
It's a theme. We're working past it. No worries at all. It's a sign of how we are trying to overcome being voiceless.
Yes. In terms of ways to provide services and help people, obviously the telehealth approach is making that as widely available as possible, I think, is critical. But in terms of one of the areas that I'm very concerned about is the impact that this pandemic is having on the mental health community. And in terms of things that can be done to assist or help communities, underrepresented minority communities, as well as the mental health community in dealing with this pandemic, I think include things such as one of the things that I've learned from my research, which is encouraging people, and this can be done in messaging, making sure that people understand that too much media exposure is likely to increase their distress and increase their risk of experiencing anxiety and worries and whatnot. Understanding that with this novel threat, that novel threats can be more worrisome. So the best way for us to address what's going on in the society is to provide people with accurate information about what the risks are and how they can handle them and what they can do to protect themselves. So you actually give people, with your advice, some power to do something. Because one of the things this pandemic has done is it has rendered many people feeling powerless and worried and concerned because their future feels like it's uncertain. So in that kind of an environment, encouraging people by giving them accurate information, by giving them advice, by giving them tips, by giving them things they can do. What can you do to protect yourself, to take care of yourself, to take care of your families, I think is really important. And giving voice to that is essential.
Thank you. And Dr. LeBron, if you can also just speak to the fact of empowering our communities and enabling them to feel and be able to use their voices.
Thank you. Yes, and I'd also like to turn back to thinking about what healthcare providers can do. So I do want to note that the sort of initial discourse and understanding why communities of color have been disparately impacted has focused on chronic conditions. And what's becoming more clear is that it's really about the inequities in terms of the structures of our lives. And this pandemic has really magnified those inequities. So we've long known, for example, that communities of color have shorter lifespans than white communities. And if we zoom out, we see lack of insurance and underinsurance and limited access to primary care providers as being concentrated in communities of color. Emerging data are indicating that testing centers are more likely to be located in more affluent communities than in low-income communities. And if the pathway to getting tested for COVID-19 is through your doctor and you don't have insurance or a doctor, then we can see how testing becomes a privilege. And so I really want to encourage us to think critically about what the public health and healthcare systems in our country and in Orange County can be doing to mitigate the inequities in COVID-19. I also want to note that a growing literature documents bias from providers in their treatment towards Black patients. And there was a very recent study that found that despite having the same symptoms, Black patients were less likely to get tested for COVID-19 than white patients with the same symptoms. So the real culprit here is inequities in the environments in which we live, learn, work, and play. And so I'd encourage any healthcare providers to really use their position within their organizations to advocate for equity in the conditions in which people are living, to advocate for equity in testing, in tracing of cases, in treatment, and in what our protracted recovery will look like. So communities are certainly working to address this as well. We've seen households and neighborhoods and broader communities really gather together from a distance to figure out what new systems are needed to survive this current pandemic, when it's really shown that this is a matter of life and death. And also, they're sitting with this question of what change in existing systems are needed.
Thank you. And I can't help but also be distracted too by your focus, and thank you for bringing this up on chronic conditions and structural inequities, and in thinking about the fact that minorities broadly are sharing the weight of just severe disease in so many ways, and brings me back to consider the points that Dr. Willoughby-Herard made earlier. And Dr. Willoughby-Herard, I'd love to hear your perspective, and just thinking about how chronic conditions and health issues really are rooted in the narratives and the rich narratives of our communities. And I say our communities with consideration of Black, Brown, and Asian communities who are currently experiencing a lot of xenophobia. But if you can, please speak to just the African narrative and influences with that. I would appreciate your perspective.
I really thank you so much for the space to be able to talk about the historical framing of structural disparities and structural inequities. Part of the issue, and why I wanted to share that film, Until the Well Runs Dry, is a misunderstanding about the value or lack of value of racialized peoples in our society. And so if the training primarily reinforces ideas that there's this huge population of people that are valuable, maybe for the purpose of experimentation, or they're valuable for the purpose of exploitation, but they're not the people that we're focused on in terms of healing. So that causes a real struggle in terms of the attempt to pursue equity. It's very hard to be the lone voice on a floor in a hospital. It's very hard to be the lone voice acting for inclusion and attempting to reshift when the training is not always organized around making sure that everybody benefits from the medical health environment. So I brought that documentary, and I really urge people to go and have a look at it, because it raises questions about the nature of medicine. And what I so deeply appreciate about all of the folks who have been putting their lives on the line, including many of the people on this call, is that not only do you do the direct work of educating and caring for people and putting your own health and your families at risk, but you also do the work of battling for equity, which is about a cultural change and a historical change about who deserves to live and who doesn't deserve to live. When the administration was in Arizona at the mask factory, and the song blasting in the factory, this happened just last week, was "Live and Let Die," it was a really cruel reaffirmation of a very, very old history that we are all accountable to. And if we're not willing to be accountable and honest and really wrestle with that history, that's really making decisions about who gets to live and who gets to die based on what they look like and what neighborhood they live in and what language they speak. If we're not willing to fight for that too, we're not doing the best we can. And I have some suggestions as well about things that work really well. My frame is a really interdisciplinary one. And if you all will permit me to share the screen one more time. The kinds of ways of thinking about about medicine that are part of the training that I, emerged from have to do with drawing on sociologists, have to do with drawing on public policy analysts and political scientists, have to do with drawing on transgender study and the history of medical science researcher, comes from scholarship by science writers. It even comes by community health advocates and people of faith here in Orange County who do this really incredible kind of work of making sure that our communities are not just disposed of. They're filmmakers and theologians and art critics, all who are deeply invested in changing what happens when we show up in the hospital. But none of that work can proceed effectively if we're not willing to have much deeper conversations about equity. And they can't all come primarily from the medical field. There's just too much accountability to go around and much more work for all of us to do.
Thank you. And thank you, as always, for grounding us and for introducing also opportunities to further dive into the impact of this pandemic. And in hearing what you were sharing, another thing that really, truly stood out in my mind was just the fact that a lot of communities are being ignored and their needs are not being heard, or they're being kind of pushed to the side with this perspective of who has the right to live and who has the right to die. There was a question that I'd like to introduce to Dr. Dow that was specifically focused on undocumented individuals in our community, and what are we doing and how are we speaking up for them? And I'm curious, with just in our clinical setting with UCI, if you have any feedback about that and whether they are able to get tested even as we consider these decisions and how they're made at a broader level. What are we doing here?
So, yeah, great question. In fact, at the Family Health Center Santa Ana, where it's predominantly Latino population that we serve, we now do have we have testing, and we're going to be starting drive-through testing next week. And in fact, the question that I had posed to our executive medical director is, what are we going to do about people who don't have insurance? Are we going to charge them? And because we are a federally qualified health center, we are not a free clinic. We are going to nominally bill them, but we have some tobacco settlement dollars that will cover the cost of the testing. So basically, it's going to be free of charge to those who want to be tested. Now, the criteria still is you need to be symptomatic in order to be tested. And I do recall, when, in March or so, when I was looking at the statistics, I was seeing that it was Newport Beach and Irvine that had the highest number of cases. And I was thinking, how can this be? And then now, if you look at Orange County data, it's Anaheim and Santa Ana that have the highest number of cases. Anaheim is a large city, but these are the communities that have the low-income disadvantaged communities, communities of color. So we are addressing that, just by virtue of us being a part of UCI, but still being a federally qualified health center. But the undocumented, especially the undocumented, there are resources. That's why I say if you commit to working with underserved populations, we need to arm ourselves with all the resources at our fingertips. Even undocumented, uninsured patients are eligible for emergency Medi-Cal. If you meet the income criteria, it happens to be 138% federal poverty level. If you meet income criteria, you can get emergency Medi-Cal, which covers emergency room visits. That's why a lot of our patients go to the emergency room to get their primary care. There is a nominal fee for patients to be seen at our clinic. It also covers medications like insulin. For our diabetic patients, this is a lifeline, having emergency Medi-Cal. When I go see a patient who is uninsured, undocumented, and our patients hopefully feel safe, because trust is a big issue with these communities. When we ask, do you have papers? And they say no, and they're forthright about it, then my first conversation is for them to get emergency Medi-Cal and make use of all the resources that are out there, not just emergency Medi-Cal, but food pantries and other relief funds. Even undocumented, I heard, are able to get $500, in fact. So it behooves us. We are obligated to advocate for our patients, whether they're undocumented, whether they have Medi-Cal or have the best insurance, to make sure they get the proper care that they need, the highest quality care that they need.
Thank you. And I want to follow up on that with actually a question to Dr. LeBron. And Dr. LeBron, you've done a lot of community engaged work, especially in partnership with the Madison Park Neighborhood Association in Santa Ana. And I would really love to get your thoughts about how we can actually increase our inclusivity in promoting those services. And I also, Dr. Holman, want to follow up with you too, just to ask about vulnerable populations within vulnerable populations. So we often think broadly about Latinx and Black communities and also individuals with special health care needs, but we don't always have conversations about those suffering from mental health and how the impact of mental health can also be further isolating, especially if you are a victim of violence. But so I will follow up with that too. But Dr. LeBron, if you can please speak to the community engagement piece and what we can do to really just link the community to the resources that exist and buffer the fear and misinformation that is available.
Thank you. Yes, so communities are certainly stepping up to address the needs for economic support, for housing and food in ways that affirm each other's dignities. And we know that households and communities are thinking together about how to really enhance their autonomy in this protracted pandemic, given their exclusion from sort of multiple efforts to address the economic impacts of the crisis and given the disparate impacts of the public health strategy on their day-to-day experiences. And so I think, this is an important opportunity for anyone who's interested to reach out to the community-based initiatives who are leading mutual aid efforts in local communities. So thinking about community-based organizations, grassroots initiatives, and faith-based organizations. Certainly there's a lot of mutual aid effort and food banks, and I want to really point to the need to advocate and use sort of our position to ask our leaders to better support these initiatives. We hear a lot of stories of people spending endless hours in line at food banks, right? So we know that even the systems that communities are scurrying to put into place are struggling to meet the profound need. But certainly there's a need for person power, a need to advocate for our governmental representatives to support communities with the resources that are needed. And there may be opportunities to also be an informational bridge to affected communities from places like UCI and other research that's emerging around this novel coronavirus.
Thank you. And definitely is a firm reminder to vote, and want to make sure everyone also is engaged in their communities and promoting that. So we need to make sure that those conversations are happening and that we aren't feeling isolated as if and preventing ourselves from feeling like we can't do anything. And Dr. Holman, just to come back again to just this concept of isolation and the vulnerable within the vulnerable communities, if you can please speak to that and just the effect of just this traumatic dose we all are experiencing.
Thank you. I got my mute. So one of the things I wanted to mention is just as a nurse, as a health professional and as a nurse, I think when you're talking about, there's lots of ways of being invisibly sort of vulnerable. And one of them is mental health. And one of the things that's really important for us as nurses and doctors, health professionals, all health professionals, as advocates for patients, our patients, especially the most vulnerable patients, is to understand that we have our own biases. And we have those biases. We don't know that they're there. They were touched on earlier by one of the other panelists. But those biases are there. And I think it behooves all of us to take the time to reflect and really seriously think about, my job as a health professional is to be an advocate for my patients, all patients in all communities. And how can I reflect on my own potential biases that may make me make a decision that could have a life-altering impact on somebody else's life? And so reaching out and really trying to touch people, understand what's going on with their lives, understand that many of the people who come from the most vulnerable communities, whether they be underrepresented minority communities or mental health communities, have experienced significant trauma in their lives. And that trauma is a profoundly meaningful piece of their life that has helped to impact who they are today. And we need to provide the kind of care that's informed by that knowledge. And there's different kinds of trauma care. Trauma-informed care is one. There's another that's called healing-centered engagement, which is really about finding the strengths in people and helping people find strengths in themselves. And I just want to encourage my colleagues and our patients as well, our community members, to be advocates for understanding that and really reaching out and challenging ourselves to reflect and understand how our own thinking and our own biases may impact how we're interacting with our patients who maybe have been traumatized, who may have suffered serious problems in their lives in the past. So, yeah.
Thank you. And thank you for grounding us in that as well, and with an awareness of this is one dose of trauma, but it doesn't capture everything that happened before this current phase. And there's the historical narratives that influence our realities and the structural inequities that exist. And there's individual narratives that also contribute to that and are now made manifest in differential ways for different communities. And it's terribly difficult to witness, and it's painful to experience, but it is a shared experience that we have to recognize as happening. And it's important for us all to make sure we're allowing conversations like this to happen so that communities' voices can be heard. The time is kind of moving towards the clock is moving towards our 2 o'clock timeline, and I want to make sure to have the chance to hear each of you share your just perspectives about what we can do moving forward, what actions we can take. And there was a question that was introduced at just the point of how do we help patients and promote evidence and kind of essentially remove myths and when people are not trusting the data that is out there. So with consideration of addressing trust for communities of color in particular, definitely want to make sure that we include that and in your conversation. So I'll start first with Dr. Willoughby Herard. If you can, please, especially with your lens as an equity advisor, please speak to just this fear and the feeling and lack of feeling safe that is pervasive. And as you talk about your final thoughts, and definitely want each of you to please share your final thoughts and include anything that you think we have not had a chance to speak to thus far.
I just want to thank you all for creating the space for us to have this conversation. I know it takes a Herculean effort just create an opportunity for people who, again, are on the front lines, working with communities and working with families that are dealing with illness, to take a step back and reflect on best practices. I really, really, really appreciate being able to be a part of this and to be able to witness the persons who are so committed to keeping us healthy, doing that work together. So because I come, I heard that the sound quality wasn't good. Is this better? Is this a little bit better? I'm hoping. So because I come from the vantage point of political advocacy and consciousness raising, some of the things that are always really important for me have to do with, like I mentioned before, interdisciplinary approaches that go beyond the medical field. I take a lot of insight from things like birthing circles, where people are given an opportunity to talk about openly with people that they trust what their experiences are, as you're trying to give them more of a sense of what their options are. I think political education and consciousness raising is very, very important in terms of people's being able to access healthcare, particularly when they're experiencing, fear. So one of the things that works in birthing circles is sharing films and people sharing readings together. And I know for the doctors and nurses who are on this call, you don't have that kind of extensive amount of time with people. What you have access to maybe is a pamphlet that you can share with them, or a handout that you can share with them. But really, to the extent that we can honor what people are telling us, not just about the immediate hurt, but to the extent that we can create spaces to honor the set of hurts that the new hurt is sitting on top of, it's more likely that we'll be able to build the kind of lasting relationship that allows us not just to, heal that individual, but to heal all the other people that they talk to. You take that moment with one patient and you build that site of trust, and they will be able to know that they can bring other people. They can say, go and see that doctor, go to that clinic, talk to that pharmacist, because that's somebody who's going to treat you with an enormous amount of dignity, but not just dignity, they'll actually care for you as a person. It's not, accidental that theologians and filmmakers are all wrestling with this topic of what we think health is and what we think wellness is. It's because as human beings, we all, at some point in time, are going to have to depend on other people to help us stay well. So there's a repository of information about healing that's outside of the site of diagnosis and medical practice. And I just, I can't say enough about how important it is to bring those other voices in.
Thank you. And I'll go to Dr. LeBron and then Dr. Holman and Dr. Dow. And if you can, please just share just one or two sentences.
Thank you. So I'd say that we have a lot of work to do in terms of doing a better job of testing and treating low-income communities, communities of color, and immigrant communities. So I'd encourage our healthcare systems and public health agencies to focus on that. We also need to shift our gaze to thinking about how we're going to get out of this storm, or this holding pattern, in an equitable way.
Thank you. And Dr. Holman?
Yeah, I'm just going to be very quick. I think we need to remember as advocates that we need to advocate for targeting resources, allocating resources to the communities that are being hardest hit. We need to advocate for that and advocate for that and advocate for that. Get the resources to the communities that need it.
Thank you. And Dr. Dow?
Yes, Dr. Holman, you took, I was going to say exactly that. In public health emergencies, it's the communities at risk the most that we need to prioritize. We need to prioritize the needs of those at-risk populations, since we're all interconnected. And if we take care of the most vulnerable first, we may have better outcomes overall for all communities.
Thank you. Again, I thank all of you for your time and for this robust discussion and for the honesty that you shared and in-depth perspectives that you have really brought to light. And I do want to give Dr. Mayes the ability to close us out, but just before that, want to acknowledge the fact that we all have a responsibility to care for our circles, and then and so we serve as role models to others. And so with that, I'm going to put my mask on before passing it on to Dr. Mayes.
Thank you so much, Dr. Taylor Lucas, and wow, what a compelling conversation. And on behalf of the College of Health Sciences, on behalf of Lead ABC, I really do want to sincerely thank our incredible panelists and our incredible moderator. As challenging as these times are, it brings me some comfort just knowing that each of you are on the front lines battling, as Dr. Willoughby Howard put it, justice and health equity. So thank you again for your time, your incredible leadership on behalf of the UCI community. I'd also like to once again give our thoughts, our compassion to all of those who have been directly impacted by the COVID-19 pandemic, and also our gratitude to those health professionals and others on the front lines. And a big thanks to all of you who joined us for this webinar. I hope that you and your loved ones keep well. Until next time.